I had the pleasure today with our Chief Academic Officer, Sandra Aguilera, to tour a few schools and was just so impressed with our staff, family, and students. Everybody is doing something new that nobody in generations remembers. But here we are working hard to support our families and staff and keep everybody safe. For the last couple of months, nearly 6,000 community members have attended our information sessions focused on our actions and plans for reopening campuses. Tonight, we will be focusing on health, medicine, science, and safety. Since the beginning of this pandemic, we have said that we have to be grounded in science and guidance from our public health partners. Our understanding around COVID has come a long way from this past year. There are new headlines and studies and blog posts everywhere. It's hard to keep up. That is why I'm thrilled to be in company tonight with our partners from UCSF Pediatric Advisory Task Force for this presentation and discussion. They have been giving information sessions focused on families over the past month, and a little over 1,000 families have joined to learn more. The goal of tonight's presentation is to help provide you with the best, most accessible, and most up-to-date information on mental health, vaccines, and COVID safety in schools. Now, I know that there's going to be lots of Q&A. There's always lots of information to digest with this topic. So please post those in the chat, and there will be staff there monitoring so that we can answer as many questions as we possibly can. And obviously, we will take back anything we can't answer and provide that to you at a later date. At this point now, I'd like to turn the conversation over to Ms. Santoy Trotter. She is amazing. She's been wonderful to partner with. And she is a school-based professional health, behavioral health, and trauma-informed systems coach at UCSF Benahoff Children's Hospital here in Oakland. Importantly, she has direct experience with our students in Castlemont and McClymonds high schools. So without further ado, I will virtually pass the mic to Ms. Trotter. Thank you for being here this evening.
Thank you, Superintendent Johnson-Trammell. I'm really glad to be here with you, Oakland Unified School District, on this day of transition and transformation in some ways. I am also here with my colleagues, Dr. Naomi Burdak, who is an Associate Professor of Pediatrics and Policy at UCSF, and also leads our California Safe Schools for All team. And with Dr. Emily Frank, who is also a pediatrician at UCSF, as well as a teacher at Life Academy, and Dr. Monica Gandhi, who is the infection disease specialist at UCSF Benioff Hospital, at UCSF Hospital. Please forgive me. Really grateful to be with all of you today. I came here and kind of rushed here from Castlemont to be with all of you today and on this day of return. Next slide, please. We want to just remind you that our goal is to partner with you, Oakland Unified School District, families, with students, with teachers, with staff, administrators, by providing accessible, trustworthy scientific information to reduce the risk of COVID-19 transmission. We are independent medical providers here just to offer our expertise and to join with your expertise, right, to provide some support to better understand the existing data and guidelines. We know there's information coming from everywhere and all sorts of information, and we want to give you the most up-to-date scientific information so that you can make good decisions for yourselves. New data is coming out all the time. What's true today can change tomorrow. And so we updated these slides today. They're fresh off the press, and you're going to have the most up-to-date and accurate information. Next slide, please. We are part of a large community, a large group, and so the four of us will be speaking with you today, but I want everyone just to take a moment and to notice the expertise that has gone into creating this presentation and conversation with you today, including some people I know who are here, Dr. Long I saw earlier, also Dr. Gaspar Rivera, Dr. Lee Atkinson, McCoy, many people have come together to create this presentation for you today. Next slide, please. And so here's our journey. We're going to start with health equity. We are rooted in a commitment to make sure that everyone has the most optimal health possible and removing barriers to health and health outcomes for everyone in our community. We want to talk about mental health concerns. When we talk about health, we know there's physical health, but our physical health, mental health, emotional health is all connected. And I'll be speaking to you a little bit about that. We know that we are opening Oakland Unified School District today, going back into the buildings, but that we have lessons to learn from school reopenings across our state and across the country. And we'll also share about COVID transmission and how to mitigate risk in the classroom. We'll share updates on vaccine variants and implications for school reopening. And in between, we'll have time for Q&A. We want to acknowledge also, next slide, please, that our values and the values inside Oakland, but also our values as a committee and values of trauma-informed system, that they're rooted in transparency. And so we will be sharing with you information that we have, as well as letting you know when we're sharing information. Maybe I might be sharing information as a psychotherapist and MFT, maybe at some point share information as a mom of a 13-year-old who's feeling both excited and nervous about returning to school. So we'll be very transparent with you, both in information and also in our roles as we share stories. We are committed to the safety and the well-being of all, physical safety, emotional safety of everyone in the school building. We are rooted in racial equity, and we know that this is a time, like many others, where we are feeling, some communities even more so, feeling the pain of racism and racialized violence. And we want to acknowledge that. We want to make sure that we are doing what we can as a medical and health community to decrease any of those disparities and health outcomes, and to address the disparities that have been here for a long time. But that COVID-19 has really shown a light on and highlighted for us as a collective community. We're here again to collaborate with you and to empower you to make the best decisions in your classroom, for your school, for your family and your community. And we know deeply the resiliency that is part of Oakland, that is rooted here. We see it. We saw it at the beginning of this pandemic as teachers worked so hard, so very hard, to provide the best quality education for our families. I'm tearing up just because I, have seen it as a parent and also have seen it as someone who works close proximity with school teachers and educators. We are so grateful for your resilience, your recovery, both, last year in March and here again as we return to the classroom. This image here is called After the Storm, and it was created by Kadir Nielsen, and he painted it, African-American artist painted it at the beginning of the pandemic. And, he shows us all kind of looking towards the light, right? There will be something after the storm. We are moving towards the future and headed in the same direction. And so just really painting this image of hope. And I hope we can feel some of that hope together today. Next slide, please. So we're going to start with health equity, as I shared. We are very aware, and if you can come to the next slide, that our communities have been impacted differently by COVID-19, that there are some communities that have had greater amount of loss, of death, of COVID-19 transmission, while already meeting the challenges of that our communities have. Next slide, please. And already meeting the challenges, thank you, of our communities have impacted through health disparities. And so because of that, there is mistrust in our healthcare systems and medicine. You know, some people are like, vaccine, what vaccine? And that distrust from the field of medicine comes because medicine has systematic, like any other system, systematic racism and oppression lives inside of the medical and health system. And we are aware of that. We are here to name it, to acknowledge it, and to know that we are doing everything that we can to transform that system. We are aware that there are poverty and education gaps, housing instability, and lack of healthcare that put racial and ethnic minority groups at higher COVID risk. We know that many of our young people are high school students. You know, at the beginning of this, we're going to work in nursing homes and grocery stores. You know, many of our young people have become the breadwinner for their families, and we are aware of the greater risk that has put them in. We know that some of these strategies to slow down COVID-19 transmission have also harmed, unintentionally impacted communities due to lost wages or increased stress and other consequences. You know, I think about the young people that we serve and all that they're doing right now to support their families and their well-being. Next slide, please. We are one Oakland, and this is an image of Oakland here for all of us, but we are different neighborhoods, different communities. And you see here the dark red, the dark blue, the same images in East Oakland. This community has been more deeply impacted by COVID-19 transmission and also loss and death. We are working together to make the best decisions for all of Oakland, you know, and as we do that, we also are taking into account that COVID-19 for all of us was stressful, right? You know, whoever's here, right? There was a stress, it's a change. And the way stress, our bodies are designed to deal with stress, and any change in our system can feel like stress, even today. There's good stress and bad stress. But for some communities, it was more than stressful. It was a compounding trauma, loss, death, grief, poverty. And we want to pay attention to those communities that were most hardest impacted by COVID-19 and the impacts. We want to also hold here that we want, you know, in terms of thinking about communities that are most impacted, the communities that are also most impacted by lack of trustworthy information. You know I had someone who, you know, showed me, oh, look, my son is sending me all of these texts, all of this information, I don't know what to do. But those communities that are already vulnerable are those communities that might be most impacted by false information. And we are committed today with Dr. Nunez-Smith to provide you scientific information, evidence, and data that you can trust. So we want to spend some time talking about mental health considerations for reopening. And we're already, you know, there today. Again, schools have reopened and some students are there, teachers are in the building today. We know that we are all, again, impacted by the mental health impacts of COVID-19. We already, for young people, we're already experiencing some of the teens and families that are here in our communities, already experiencing stress, anxiety, depression. Part of the reasons why we have school-based behavioral health services in school is to prevent and early detect. But some communities are greater impacted because of racism, discrimination, grief and loss. And right now, I just want to speak to, you know, especially for our Asian Pacific Islander communities, the rise of violence towards elders and family members, and also for Black Latinx families, that the impact of racism and that impact on mental health and well-being. And so we want to pay attention also to our LGBTQ communities as well. And what can we do together? One of the things that we can do is be in solidarity. So acknowledge your feelings, right? This can be a scary time. It's a time of change. Be compassionate to yourself and give some grace and compassion to your colleagues as you're returning, to your family. When you see something, say something, whether that's happening in a Zoom room or in a conversation or in the community, speak up. We want to explore and learn more about each other's cultures. And these are just some ideas for solidarity. I know that there are others. I know that Oakland is rich in solidarity. But keep having those communications with family and friends. Support local small businesses. So I want to talk right now specifically to teachers and to staff. Right? Before we think about mental health and well-being of students, family members, I want to think about you. I want to take some time to acknowledge, one, how incredible you have been during this time, and also acknowledge the stress and the loss that you may have experienced. And some of that loss is that loss of rituals, loss of graduation, loss of, even getting ready for prom or even some of the senior activities that we have. And also many have experienced loss, and not just due to COVID-19. There's been other losses that people have experienced, deaths that people have experienced. And so it's important for you to acknowledge that for yourself, acknowledge that with your colleagues, and that this is a period of change and transition. I was talking to a teacher friend recently, and they said, one of the things about this time is that there's been permission to not be okay, to really name when we're not okay, and to acknowledge that. And we need to both right now acknowledge to our colleagues, like, oh, these are the ways that I'm doing well, and these are the ways that it's hard at this moment, this transition, and maybe be truth tellers, right? Truth seekers, asking each other and really listening for, how are you doing? I know for many, it's about to be April, and this is the time, okay, we're moving towards the end of the school year, and now we're requesting another big lift and change from you. So expect and prepare for social anxiety and social exhaustion. Even if it feels happy and well-being, at the end of the day, you may feel more tired. We haven't, been around that many people. We haven't been in a school building. And so be prepared for that. Schedule time for rest over the weekend or in the evenings as much as you can. Set your boundaries and hold them. We're going to do all that we can, and you can't do everything. We can't do all of it. And there's a team and other people here to support. So really want to encourage that, so that we can have you here, through the end of the year and beginning next year, and really lean into community care. I think that's one of the things with our team that has gotten us through, taking care of one another, and want to encourage folks to lean into and seek out community care, ways to do things together, celebrate together, and even mourn and grieve together. It's important to do that. Want to invite folks to lift up the resilience that you see in yourself and your colleagues and your students. Celebrate, clap it up, snap it up. I know that we have a culture of celebrating successes. Do that at the end, at the beginning of every meeting. Lift up the things that are working while we make mistakes. There's going to be some challenges as we start right now. Allow for that. And I just want to leave you with the EAP number for Oakland, for you to have support for counseling and therapy. So that's here for you to access. So I know that Oakland Unified School District, that we are familiar with trauma-informed and resilient classrooms. And so this is just a reminder, just a refresher for all of us. I heard even today that there is safety and predictability, right? Orienting, so where's the door? What's our procedures? How are we gonna come in? How are we gonna exit? So all of this, as much as we can, create safety, physical and emotional safety, as well as helping people understand, we may not know all of what to predict, but this is what's gonna happen today. This is what's gonna happen next. This is, all of that guidance, leading as much as we can, even today's presentation, right, will help rest the nervous system, right? Will help, people feel a sense of, okay, we might not know the answer to everything, but at least I know what's going to happen in the next 30 minutes. Write it on the board, give them information in many different ways. Have welcome, greeting, we're glad you're back. And for those who are staying at home, we support you. We're glad you're making the best decision for you, right? Validating, make sure that we're including those who are still working remote, doing school remotely, as well as celebrating and those who are coming into the building, right? We want to welcome, greet, and celebrate everyone. Validate all the choices that people are making right now. One thing that helps with our mental health when we've experienced a loss or trauma or stress, we are meaning-making machines. We're always making, what does that mean for me? What would I want to learn from that, right? And that meaning that we make will have an impact on how we recover from that experience. And so here's an offering by Candice Venezuela, which is a ritual for routine. Being able to, and I can put it, send this out to everyone, but creating a place where, you know, it's sanitized, but maybe there's art supplies and people go up one at a time and ask questions like, what has this time meant for you? What did you learn about yourself? What did you learn about your family? What are you looking forward to for this summer? What are the stories? What was start to, you know, school like? So playing a place where people can create rituals, image, drawing, and words and make meaning out of this time. You know, we talk about this being a time that, you know, everyone's like, well, what's going to happen at the end of the pandemic? And we're not at the end of the pandemic, but we are in a place where we can more safely come together and be safe in schools. We want to encourage people to connect with students and refer. You know, there are people there for mental health services, and we want to make sure it support you to connect and refer and be transparent about what's working, what we know and what we don't know. And we know that we're rooted in love and hope, and want to encourage people to continue to express that love and hope. And so just lastly, a reminder of the mental health resources that are available for you: costs, school-based health centers, behavioral health program managers, that we're there to support you. And I know that Barb McClung and her team have sent out information and are already ready with so many resources that they have shared, and just want to reinforce that. And lastly, I want to just encourage people to ground, right? This is from Daniela, who is a Youth Wellness Advisory Board member from McClymonds High School. And she says that resilience is when we are able to lift up from something that has been very hard. And, you know, from Daniela, we know that as Oakland, we can lift up together. And so I will pass it now, and really appreciate all the Oakland Unified School staff wellness champions. Thank you, Mara, and get to pass it to Dr. Naomi Burdock, or see if there's any questions.
Yeah, thank you so much, Ms. Trotter. A couple questions have come up in the Q&A. One is, what might stress look like in students and in teachers?
Thank you for that question. So stress can look like anything in your body, right? Clammy hands, racing heartbeat. Stress can break, you know, our bodies can somatize and show stress. So it might be noticing changes in temperature, feeling really warm, feeling really cold, feeling hungry or not hungry, right? Like kind of, oh, I stopped. I'm noticing I'm not eating anymore. I'm noticing I'm eating a lot. So that's, our body metabolizes stress, but those are some of the ways that stress can look like in children and in teachers. Really important to know that we can co-regulate with each other. So for teachers, when you're in front of the classroom, any of these co-regulation strategies of mindfulness, right? We're going to do box breathing, breathing into 4, breathing out for 4, you know, exhaling. So that's something we can do. Having everyone stretch together, holding your hands, kind of cupping your fingers, right? Hugging yourself, right? There are many different mindfulness exercises that we will share. But that's kind of, these are, as if you are, as a teacher or educator in a classroom, if you are starting to feel stress and you know what that is for you, take a moment and do something that is relaxing for you, and it will be so for your students.
Thank you so much. All right, next we have the opportunity to hear from the wonderful Dr. Naomi Burdock about what we've learned in the last year about school reopening and safety. And then we're going to switch up the order so that we have a chance to hear from Dr. Gandhi about vaccines and variants.
Okay, thank you. And I'll agree that stress looks like many things. And my child at home, sometimes he gets really irritable when he gets really stressed. So that's the other thing sometimes that comes up for folks. Next slide, please. So the talk that I'm going to be giving, I just think it's helpful, and thank you so much, Ms. Trotter, for such a wonderful sort of framing of this conversation. Part of what I'm talking about is actually sort of the scientific evidence, as much as we know about, you know, how to create safe schools, or what does a safe school environment look like. And I think it's helpful. I really appreciated the call out for transparency and what are the different hats we're wearing. I wear a hat of looking for the best information possible. So sometimes people say, oh, Dr. Bardak, she just, believes in XYZ. She only is looking for information about school reopening being good. Or sometimes people are only looking for school reopening being bad. And the commitment I have made in general to this whole endeavor, because it's so important to get it right, is that I always look for the very best information we can get. And so that's what I'm trying to share with you today, to help you guys begin to understand the best scientific information we have to inform how to do a safe school. So the pathway forward is this. What is this? Big, wide open road, but there's two guardrails. On one side, the possibility in COVID is to open up schools too much, just everything open, no safety mitigation at all, no safety guards, nothing. And we've seen that that can lead to outbreaks. Early in the pandemic, we saw that there were a lot of outbreaks. That meant no masking, kids all packed in, no ventilation, no physical distancing. That's one side. We need to protect against that. That's not good for our teachers, for our students, for our families. On the other side is kids staying in school in distance learning and not seeing even a single day of in-person learning for too long. And we know that that has terrible effects for our students, for our mental health as a community, that it's really hard educationally, and that it drives inequities deeper if we're not paying very close attention to being able to help support those kids as they're managing distance learning. And I'll echo Ms. Trotter's comment that the work that teachers have done has been extraordinary. And so now today is the first day to also help support extraordinary work in a way that is also psychologically and mentally sort of feeling like you're in a safe space and that the kids are in a safe space. Next slide, please. And the pathway forward is not this, crashing off the road. So how do we get there? Next slide. So we know more now than we did in March 2020. Early in the pandemic, we all thought every kid is going to spread this virus everywhere. We got to shut down the schools. Next slide. And what do we know? Here's kind of the summary of what we know. Children get COVID-19 less often and are less ill than adults. And sorry, I like to give the take-home points first so that all the data sort of sits a little bit more easily in the brain, which you probably all know as educators is sometimes a good way to do it. So COVID-19 less often and are less ill than adults. Children do not seem to be major sources of transmission to each other or to adults. Transmission in elementary schools, however, is different from high schools, especially if there's no masks involved. Adult to adult transmission is the most likely in the school setting, but also therefore where we have the most control. Community prevalence is going to affect school-based cases, how many cases are in the school, but not necessarily in school transmission, which is what is the really, really key piece. We know outside of school, inside of school, cases go up and down. But the in-school transmission, where one case goes to infect somebody else, is what we really need to make sure we're putting those safety layers in place to stop. What are those safety layers? Masking, physical distancing, stable groups, ventilation, hand hygiene, symptom screening and screening for contacts, and surveillance testing. You'll hear these themes throughout the talk. How do we do those things? And what's the evidence behind that? Dr. Frank is going to tell, or Ms. Frank is going to tell you more about how to do it, and I'm going to tell you sort of the data behind it. Next slide, please. So just very briefly, a question I often get is, why do children get COVID-19 infrequently with less severe disease? And there's a good study that came out actually early on in the pandemic that helps to understand or explain this, which is that ACE2 receptors, these are these things on the cells called ACE2 receptors. They are the entryway for COVID-19 or SARS-CoV-2, the virus that causes COVID-19. They are how the virus gets into our body and leads to the infection. And it turns out that the ability to make ACE2 receptors, these doorways, varies with age, with elementary school aged kids making less of the ACE2 receptors compared to middle and high school students who make less ACE2 receptors than adults. So the implications are, if you have fewer doorways, less likely to have disease, and actually also more mild disease. Next slide, please. The other thing we know is that transmission among or from students is uncommon. And that's illustrated by one tiny case and also one really huge study. And the tiny case is just a sort of illustrative story that sticks in the brain. There was a French 9-year-old boy early in the pandemic. He had co-occurring, meaning at the same time he had both influenza and COVID-19. He went to 3 different schools. He had 80 different contacts, and there were 0 cases of COVID-19, but there were influenza cases. So that teaches us, like, oh, our normal mental model is that kids pass things around. It's just not happening with COVID-19 in that way. And the next study from Australia, huge study, 10 early childhood centers, 15 schools, over 6,000 people, showed overall very low numbers actually of COVID-19 and of people getting COVID-19 in those centers. And that's similar to actually more recent data from New York, because generally speaking, schools actually are a very safe and stable environment. Those who did get it, 90% of them got it from a household contact. So it's usually adult in a household give it to a kid. Transmission in the schools groups, you can see child to child, very infrequent, 0.3%, child to staff, 1%, staff to child, 1.5%, staff to staff was 4.4%. That's 4 times more than the child to staff. And that's just because adults pass this virus around much more easily than children do, which is, again, gets to this point of we actually have control over our actions as adults. And so we can protect ourselves from passing around from adults to adults. Next slide. So why don't children transmit as efficiently? You know, we just said they're not going to get it as often, but why don't they give it as often? And there's just some practical considerations. We don't have great science behind it, but we sort of know intuitively. There's a couple things to point out. One, they have smaller lungs. So that means when they cough, they make smaller clouds of viral particles. There's just less virus in the air to pass along. They have less severe disease, which means they don't cough as much, which means they just don't put out as much virus again. And then children are shorter than adults. So to the extent that COVID-19 passes by something called respiratory droplets, which Dr. Frank will tell you more about in a bit, there's both heavy and light ones, and some of them, the heavy ones go down. And if you're a kid, they go down and they don't go up to the adult. So they're just less likely to transmit. Next slide. Early on the pandemic, and even July and September, this was a story that sort of started to spread. And I think it's really helpful for people to understand that people said, aren't children super spreaders? There were some studies that came out, people got worried, maybe they're equally infectious or more infectious than adults. So I just like to talk about these studies briefly to explain them and help put them into the context of how we make a school safe. So one of the studies looked at kids with mild or moderate symptoms. They found that there were higher viral loads in children under 5 compared to ages 5 to 17 and 18 to 65, but they only tested symptomatic children. And it was early in the pandemic when we were really not testing kids almost at all. So those kids probably were pretty sick. And so it's not totally surprising that they might have had higher viral loads. The second study is out of India, 85,000 cases, 575,000 people were traced in the home environment. And they found that children were more likely to infect other children their age. If you were a kid and you passed it on to somebody, it tended to be somebody your age, oftentimes because they were your siblings at home. And adults aged 20 to 44, though, were still the most likely to infect others. So what do we learn from this? There's a couple limitations, one of which is that we're just talking about viral loads in the first one. And the second one is the risk of transmission. We didn't really understand exactly what's going on there. People talk about, maybe it's the interactions with kids in homes, no masks, et cetera. And the other really helpful take-home point is that they only studied in both studies children who were symptomatic. So that means that this recommendation of do symptom screening, ask people to stay home when they're sick, whether you're an adult or a kid, stay home when you're sick, and that will cut this risk of transmission that we found in some of these studies. Next slide. So where are children getting COVID-19? This is a really nicely done study that actually was out of the CDC, the National Center for Disease Control group, and they looked at a group of students or children who had tests for COVID-19, and some of them were positive and some of them were negative, and they asked a whole bunch of questions. What were you doing? What kind of behaviors were you doing? So compared to the children who tested negative for the virus, the children who tested positive were more likely to have attended gatherings like weddings, parties, play dates, or funerals, but were not more likely to have attended childcare or school in person. So there was an equal number of kids who had attended childcare or school in person in both groups. It didn't increase their chance of having a positive test. Next slide. Another important study came out of North Carolina, and this is helpful because it talks about transmission in schools when there's high community prevalence, large numbers of cases outside of the school. It was a study from September to November in 2021, and they had community rates up to 29 cases per 100,000 per day. That's higher even than you're allowed to open an elementary school in California under California rules. If you are in the purple, you're higher than 10, and if you're in red, you're less than 10. So that's pretty high. They had a group of schools called the ABC schools. They focused on the 3 W's: wear your mask, wait 6 feet, wash your hands. They had 773 community cases, meaning cases in schools, that positive cases of COVID, but they only had 32 cases of in-school transmission, very, very low in those schools. And it was partly associated with very specific things that we can learn from. 3 clusters in the ABC schools. One was due to no masking in a pre-kindergarten, which is now a recommendation and that they changed in response to that. And then 2 in a special needs setting, 1 with eating in close proximity. So again, things that we know, actionable lessons that we can change and not repeat those mistakes. And they found there were no child to adult transmission cases. Next slide. They also found that North Carolina residents with COVID-19 during that time period infected approximately 1 other individual. So if the same number of transmissions occurred in schools, there would have been 800 to 900 cases in the schools, and there were only 32. So they talk about a couple other reasons for success: detailed plans, public reporting, and very importantly, the ability to share lessons learned peer-to-peer, which is part of what this group is also doing, is helping people learn, bringing people together, doing collaborative work. So the implications from the study are that mitigation strategies can make a difference, and they're key to our prevention, especially with our high community rates, and that data suggests that schools are actually safer than the community with those mitigations in place. And I like to give a lot of credit to, as Ms. Trotter was pointing out, routine, stability, peer groups doing the same thing together really allows for this, for safety to happen in schools. Next slide. This is a study also demonstrating limited transmission with masking, stable groups, and physical distancing. It's K through 12 schools in rural Wisconsin, and they had mandated masks. They had groups of 11 to 20 students, and the staff maintained 6 feet of distance, but the students actually did less. They did closer to 3 most of the time. And they had very little in-school transmission. They had 7 of almost 5,000 students had an infection during those 13 weeks, and 0 of the 600 staff. So no spread was known to have occurred in the staff or school, despite some times with very high community spread in that way. Next slide. Really helpful to highlight what we understand about high schools being different from elementary schools. This is from 2 studies coming out of France in the same region of France early in the pandemic. No precautions at all, no masks, no stable groups, no nothing, no ventilation. Community prevalence at the time was 9%, and they figured that out actually by testing everybody's blood to see, did they have any sign of having had COVID in the past? That's called an antibody test. In the high school, they found that there were 43% of teachers and 38% of students had been infected, had some sign of having been infected. In elementary schools, 7% of teachers and 9% of students were infected. And the implications is that transmission can occur in high schools, but the community prevalence tended to be reflected in the elementary school cases. Next slide. And this is just a visual representation and sort of a modeling of what the elementary and secondary schools is the middle school and high school, sort of why it helps to explain. The two explanations, one is that ACE2 receptor story, the doorway into the body that we talked about in the very beginning. And then the other one is this, it's a structural piece, which many of you guys know. The elementary schools tend to be very naturally in stable groups, and those secondary schools, lots of mixing. So if there's an infection, it's easy for it to get passed around between the students and the staff, actually, because staff also tend to move around their classes a lot. Next slide, please. So the other question that many people ask is, there's all these things. It's a long list. There's masking, there's physical distancing, there's ventilation, there's hand hygiene, testing. Do we have any sense of what's going to be more effective? And so this is a study that came out of Berkeley, actually, UC Berkeley. They did a modeling study where they surveyed a bunch of people actually early on in the pandemic to talk about what their interactions were before the pandemic between work and school. And then they modeled what it would look like if people went back to school in the fall. And they looked at the effects of 3 different types of interventions: testing up here on the top, masking, stable groups, and then combinations of things. And you can see across the bottom the proportion of each group experiencing symptomatic illness over the fall semester, which of course we want to prevent that symptomatic illness. So you can see in teachers and students and household members. And I know that there's concern both for the students as OUSD goes back, and also concern from the staff on behalf of household members, and also the families themselves, saying, is it safe? Is it okay for our kids to go back even in high community rates, which luckily they're coming down, but as people think about what are their risks as they come back to school. And you can see, hopefully, I'm not sure how well these slides are going to come out for folks, but you have high school in the light blue, middle school, and elementary school. This is with no additional precautions. There's a pretty high proportion of people having symptomatic illness. This is monthly testing of teachers, monthly testing of teachers and students, weekly testing of teachers and students. It moves things along pretty nicely, but this is masking alone actually is more effective than the testing by itself. And then stable groups, and then you combine them all together, it looks really, really good. And you can see the same thing for the students and the same thing for the household members over here, that you can really bring down, even with masking alone, can really bring down risks to families because those safety mitigation layers are so important. Next slide. So this is just our summary slide. We know more than we did in March, and Dr. Frank's gonna go into greater detail here. Masking, physical distancing, stay home when you're sick, ventilation, symptomatic, asymptomatic testing, and small stable groups. I'm just gonna highlight one thing, which is that symptomatic and asymptomatic testing, the asymptomatic testing is this, ongoing, a group of people, teachers, students get tested periodically, because we know sometimes COVID-19 is asymptomatic, it's not showing up. And so it's another one of the layers that people use. And OUSD is already participating in 2 types of testing. One is called a PCR test, and the other one is an antigen test. And sponsored actually by the Public Health Institute for the antigen test, to really support. The antigen test gives you results very quickly. And so it can create a lot of sense of confidence and create a really nice additional layer of safety. And so just I want to share with you guys that those are capacities within OUSD that the district is working to support, and they're partnering with the state. So the state lab has both those PCR tests and the antigen tests. Next slide. And just to summarize, I think this reflects Ms. Trotter's ideas also, which is if you want to go quickly, go alone. And if you want to go far, go together. And we got to do it together. That's the only way we're going to get through the pandemic. Thanks so much.
Thank you so much, Dr. Bardak. I learn so much from you every time you speak. There's some really wonderful questions in the chat that I'd like to ask you about, and then we'll hear from Dr. Gandhi. One question in the chat is, what data do we have about middle school?
Very good question. I have since June been looking for good data from middle schools, and we don't have great data. A lot of the studies that they do, they clump 10 to 17 together, and so we just don't have it pulled out 100%. One of the theories people have is that the ACE2 receptor story is partly driven by going through puberty, which, that sounds actually relatively plausible. So we know that there's a mixture of kids in the middle school setting. Some have gone through puberty, some haven't. That being said, the data we have about those safety mitigation layers include K through 12. And there's nothing calling out that middle schoolers are behaving any differently in terms of their transmission. And so those layers continue to be important: masking, physical distancing, et cetera.
Thank you. Another question that came up in the chat, in the Q&A, is, are there studies showing low school transmission from areas of the country more like the diverse populations that we have here in Oakland?
Yeah, great question. The data that is most publicly available is the New York City data, and they have, I haven't seen great, no, that's not true. Actually, there was a paper that came out in Pediatrics just a couple weeks ago that was specifically about New York, and they have very low case rates overall. And I don't have the data right off the top of my head, but I'm pretty sure they looked at in-school transmission as well, also very low. They did 6 feet of physical distancing at the time and had also masking and other mitigation layers in place. They did not have an emphasis on ventilation, nor did North Carolina, which I know is also a concern for all of us, you know, thinking about urban environments. So that to me is in some ways reassuring. I advise everybody, and Dr. Frank will say the same thing, optimize ventilation as much as you can, but all of these layers work together. So if there's one layer that's less perfect than another, the other layers really help to reinforce and to stop that transmission. And that's kind of the experience we're seeing across the country.
Great. And one final question from the Q&A right now, and then we'll have an opportunity for more Q&A at the end of the full presentation. Is the data that you showed us, or really sort of any of the studies, has it been tested on mutated strains of the virus?
So the experience we have, or the data we have about the variant, which generally speaking, people, when they say the mutant variants are thinking about, there's a variant that came out of UK that is more contagious than the sort of initial variant, or the initial SARS-CoV-2, the virus that causes COVID-19. It shows that it's more transmissible. That variant is more transmissible than the original one, but it actually is similar across all age groups in terms of transmissibility, and that it also is it's susceptible to the vaccine, which is great, and that those mitigation layers are still going to be effective. So we still have to do those mitigation layers, and potentially we need to do them even more. People talk about doing double masking. So that's kind of what we know about the variant itself. It hasn't been tested per se. We don't have a whole lot of data about what it looks like in schools. There's some data from Israel, but it's not a perfect corollary. They got the variant, the UK variant anyway, sooner than we did over here. And the other data to let you guys know is that we actually don't have very much of the UK variant in California. We have a couple California variants that seem to be maybe a little bit more infectious, but potentially not actually. And the UK variant hasn't really spread very much here. So and I'm watching the data very, very carefully.
Thank you, Dr. Bardak. That's actually a wonderful segue over to Dr. Monica Gandhi, who's an infectious disease specialist at San Francisco General Hospital and UCSF. She is going to be talking with us about the vaccine and the variant. Thank you so much, Dr. Gandhi.
Thank you for having me. Okay, so we'll just go to the next slide. And we'll talk about variants. But when we talk about vaccines, though, I want to actually remind us, just for our own information, that there are 9 vaccines out there. So it's a pretty amazing time to have had 9 vaccines developed so quickly. 3 of them are, we don't have great peer-reviewed data on. Those are the 3 bottom ones. The Covaxin and the Sinopharm and the Sinovac. We're waiting for the longer data on that, but the top 6 ones, Moderna, Pfizer, Johnson & Johnson, AstraZeneca, Novavax, and Sputnik, we have a lot of information on. And of course, we'll just focus on the top 3 because those are the ones that are available in this country. Next slide. So all 6 of those in that top part of it actually work on the spike protein, and boy, was that the right one to choose. And what the spike protein is, it is the piece of the virus that sticks out and binds to your cell and can enter the cells that way. And the place where it binds is called the receptor binding domain. So all of these vaccines have something to do with coding the spike protein and the receptor binding domain, that part of the virus. Next slide. And as you've already heard a lot about just in the news, of course, the Pfizer and Moderna ones are called mRNA vaccines because inside this lipid package is an mRNA genetic material that you as the host take that mRNA, make that mRNA into protein, and then that spike protein that you make looks foreign to you, so you raise a very robust immune response to it. The Johnson & Johnson vaccine, which is on the top, is a different sort of formula that it's inside a virus, an adenovirus that causes a cold usually, but it can't replicate in your body. And then inside that virus is DNA. And then that adenovirus kind of brings it in, and then that DNA, same thing, gets made into mRNA, and then the spike protein, you raise an immune response. AstraZeneca and Sputnik are also adenoviral vaccines. And then there's one called Novavax, which is just the protein, spike protein itself. But again, I'll just focus on those 3 that we have authorized in the United States. Next slide. You can't actually talk about variants or vaccines or anything about vaccines without reminding us of the immune system. So just to spend a minute on that, it's really 2 arms of the immune system. You hear probably too much about antibody responses, which are actually not the main way that we fight viruses. B cells go to plasma cells and they make antibodies. That's not the main way we fight viruses. Our enduring form of immunity and the major immune defense against viruses is cell-mediated immunity. Cell-mediated immunity is kind of 2 types. The T cells are divided into CD4 cells, which are called helper cells. And helper cells, you want a Th1 skewed helper cell response to have a good response against a vaccine or a virus. And then there's also CD8 type cytotoxic T cells. The reason I mention this is all the phase 1 and 2 clinical trials actually took the time and the effort to measure cell-mediated immunity that was developed against the vaccines, which gives us confidence that we're going to have a very in-breath response to vaccine that includes cell-mediated immunity, so that when we talk about variants, we can quell our minds when we know about the protection that T cells give you against variants. Next slide. So, this is very busy, but actually we'll just focus on the top 3 rows. Again, the Moderna, Pfizer 2 mRNA vaccines, and the Johnson & Johnson is the adenoviral DNA vector. The top 2 are 2 doses, and the Johnson & Johnson is 1 dose at this time. I told you, and this is what I really wanted to stress by the 4th column, that they took the time in the phase 1-2 trials to measure CD4 responses, CD8 and CD4 responses in the case of Pfizer and Johnson & Johnson, and showed very strong, beyond neutralizing antibodies, very strong cell-mediated immunity develops against these vaccines. They also protected macaques, all 3 of them, from getting the virus again if you re-challenge them. And then they were studied in very large populations. These are 15,000, 18,000, 22,000. These are people who just got participants who got the vaccine, and then double that for the number of people who got, or take half of that, the same amount for the number who got placebo. And the reason that I highlight this column number 6 is because they all protected 100%. Dr. Fauci really highlighted this at the White House Task Force meeting yesterday, against severe disease. So the most severe outcome, they're actually 100%, not like 99% effective, 100% is sort of amazing. And this wasn't really seen with vaccines before. So the most severe outcome that you can have, which is hospitalization and death from COVID-19, those were protected for by the vaccines. There's just 1 person, Moderna, that they adjudicated did end up going in the hospital, who probably hadn't developed the immunity, but everyone else was protected from that severe outcome. And the same is true with even severe disease where you were managed at home. Equal protection, really high protection, 100% in most cases, and we'll go a little bit into the Johnson & Johnson vaccine when we get to the data. And then mild disease is where efficacy differed, and I'll talk about that in a moment as well. Next slide. So to give you some details on these 3 trials, because these were the ones, and it's important for me to say, actually, these 3 trials are very outdated information because we have so much real world data on how well these vaccines work that I'm going to actually stress that more in this talk, because beyond the 44,000 that were given vaccine here, we've given these doses out to millions and millions of people now, right? And the effectiveness, what's called effectiveness, when what happens in real world versus clinical trial, which is called efficacy. The effectiveness is amazing. So Pfizer, 2 shots, 30 micrograms, 3 weeks apart. And of those who were reported on in the clinical trial, 50% were females, 82.9% white. So there was some African-American representation, 28%, 9.8, 28% Hispanic and Latinx populations. There was representation of people who had pre-existing conditions that could predispose to severe disease like obesity and diabetes. And it was very efficacious, meaning of the 170 people who became infected, 162 were in the people who got the salt shot, and then 8 were those who got vaccine, but they all had mild disease. Severe disease, again, it protected 100% against. And then the next slide, the Mrna trial, equal really findings, 2 shots, 100 micrograms, 4 weeks apart. This was almost 50% female. It was still, they each did enroll older individuals. So 25% were over 65 here. 36.5% of participants were from communities of color. 22% had some high risk condition. And then again, of all the total symptomatic final infections, most of them occurred out of the 196, 185 occurred in the placebo group. So it was 94% effective, efficacious. Again, there were 30 severe outcomes and they actually all occurred in the placebo group. But the FDA went back and said, there was one person who was hospitalized hospitalized for COVID in the vaccine arm. So there was one that, and they did fine, but they did get sick. Next slide. The Johnson & Johnson phase 3 trial was actually conducted across more diverse sites, meaning the US, South Africa, and Brazil. Those others were mostly in the US. And they were 45% female, 34% were over 60 years old, and more representation from communities of color. 17.2% were either African-American or African, and 45% were Hispanic or Latinx. And 41% had comorbidities, meaning they're more likely to get severe disease. But still, you saw, next slide, the incredible ability of this vaccine to prevent severe disease. 468 symptomatic COVID cases. Anyone who got hospitalized for COVID or died, unfortunately, of COVID were all in the SALT arm, got the placebo. No one was in the vaccine arm. And then against severe disease, meaning like you were at home, and we really do need the full, this is the one I showed you on the first slide, but we don't actually have a peer-reviewed report. Here we have the FDA report, so we do need a full report. But there were some people at home, but they were called that they had bad disease. There was equal efficacy across the 3 sites, South Africa, Brazil, and the US. But interestingly, in Brazil, 69% of the virus circulating was the P1 variant, the so-called Brazil variant, and 95% of the strains in South Africa at the time were the B1351, which is the so-called South Africa variant. So it was equally effective against those variants for severe disease. The efficacy varied in terms of those 3 sites against mild disease. But again, we do need the paper to understand what was mild disease. And I'll tell you one thing that I think was a problem with this trial. They looked at outcomes 0 to 14 days after people had gotten the shots. But the phase 1/2 trial showed us that your CD4 count, CD8 counts, and your antibodies keep on going up and up and up out to 59 days. So we think that it would be more effective if they had waited and adjudicated outcomes after 28 days. And I think we have 2 things coming, which is again, the peer-reviewed publication to see if that's true. And the second is the 2-dose study, which is called the Ensemble 2, which is underway. Next slide. So will the vaccines work against the variants? The answer is simply yes, and I'll explain to you why. Next slide. So I needed to explain the immune system to explain to you that antibodies, when we measure them, we actually do not measure a bunch of different antibodies. We measure once against the receptor binding domain. We measure sometimes once against the nucleic capsid, and we measure once against the spike protein. We don't measure antibodies that develop along the breadth of the spike protein. However, T cells, when I told you that they were measured, they're really complicated to measure. They take flow cytometry machines, are very complicated, but we're able to measure an in-breath response. And you develop a very broad T cell repertoire against multiple parts of the virus in natural infection. Just against the spike protein itself, multiple epitopes across the epitopes mean little pieces across the spike protein. So you're developing a very robust T cell response for natural infection. Next slide. And then after vaccine, what has been found is that they took people who had been vaccinated with mRNA vaccines and then put their blood in a test tube, essentially with variants, with the B117, which is so-called UK, B1351, South Africa, P1, Brazil, and California variant. And the T cell responses were equally intact. They were completely as robust and strong against all the variants that you developed from mRNA vaccination or natural infection, incidentally. And this was actually shown, not to get too complicated, but this was shown in the AstraZeneca trial as well. A trial was stopped prematurely, which I think it shouldn't have, but the severe disease outcomes were protected against because you had very robust CD4 and CD8 responses develop against the B1351 variant in the AstraZeneca vaccine. Actually, there were 87 T cell epitopes that you get alone, 87 parts of the spike protein that you develop T cell responses to, and 75 of them were preserved with the South Africa variant. So you have plenty to cover you. Next slide. And this is a paper just published today, hot off the press. It was highlighted by NIAID or NIH because this was supported by them. Same thing that I just said. Essentially, CD8 cells, there are 52 epitopes along the spike protein, and with any variant, the Brazil, the UK, the P1, the P1 B1351. Like 51 out of 52 of the epitopes worked with the CD8 cells were responsive against these quote mutated spike proteins. So I don't think we need to worry about the variants. I do understand the news has certainly made it not seem that way, but I think it's important to look at immunology. Next slide. So RNA viruses do mutate, but actually this doesn't mutate this fast, which is why I don't think we're going to need Emily, yes, which is why I think we don't think we're going to need a lot of booster. I don't think we're actually going to need boosters frequently. In fact, I'm not sure we're going to need them at all. And T cell responses are preserved against variants for the NIH data and the data I told you before. And sure, we can tweak vaccines in the future if need be. Companies are certainly interested in making money and making those tweaks, but I don't think they're going to be needed. Next slide. Do the vaccines reduce transmission? Short answer, yes. Next slide. I will skip this one because it's too much to go into and I only have a little bit of time. However, essentially, I told you that the only thing I want to say from the other slide, and you don't have to show it, is that IgA, which is the immunoglobulin that you produce in your nose, is produced at very high levels by these vaccines. So we always thought that they would block transmission. And then this is a nice study from Mayo Clinic where people after they're vaccinated, they keep on swabbing them before procedures, but their rate of symptomatic infection went down, of course, but so did their rate of asymptomatic infection by 80% after just one dose. And then next slide, we actually have at this point, oh, I'm sorry that one of my slides went away. Can you go to the next slide? I'm sorry, I wanted to actually show you that there are 7 studies now at this point. So and you can go back up to the previous slide, but we now have 7 studies. I only showed you one, but there are studies ranging from up to 94% reduction in asymptomatic infection. There are now actually 8 studies, including one yesterday, which led the CDC director today to comment that yes, we at this point, especially from the CDC study yesterday, know that vaccinated people cannot carry the virus. So this has a lot of implications for you not being able to transmit after you've been vaccinated, which is great for vaccinated and unvaccinated people being together. Next slide. So a couple of more slides on vaccine effectiveness, and then I'll stop. I thought you thought it looked good in the clinical trials. Next slide, the vaccines look much better in real life. Next slide, please. This is data from Israel, from the Ministry of Health, but essentially their real world program, and they put out this data very poignantly a year after the WHO declared this a pandemic on March 11th, 2021, showed that it was 97% effective against symptomatic disease and then 94% against asymptomatic infection with regular swabbing. People who are in the hospital with COVID-19, and this is true in the United States as well, are those who are not yet vaccinated. And this was, by the way, during a time where 80% of the circulating virus was B117. Next slide. Another amazing real world data, if you look at the bottom panel on the left, in Israel, they had 90% of their over 60-year-olds vaccinated. So they opened up, they stopped their lockdowns. And again, the top panel shows you that anyone who goes to the hospital with COVID-19 is not vaccinated yet. The same findings have been shown in the UK with both cases and hospitalizations plummeting, but they adopted a strategy that was unfortunately not unfortunately for them, unfortunately for us, much faster than our strategy for a variety of reasons. Next slide. This is what mass vaccination looks like in the US. This is just data from today, that in nursing homes, the death rate has gone down by 91% and cases have plummeted by 96%. The reason that community has only had a 72% reduction in cases since December is because the community is not why we have not achieved mass vaccination. As of this morning, 28% of us in the United States have received 1 dose. So we're about half the rate of Israel and the UK. Next slide. And then these are studies from healthcare workers that were published in the New England Journal in March 23rd. But you can just see, someone said to me, you don't need a p-value for that right-hand graph there. But to put it very simply, 26 out of 1,000 people before mass vaccination of healthcare workers could get COVID. And then after this, 0.5 out of 1,000 people. So you need 2,000 people and then to get 1 case. Next slide, the same findings were shown yesterday in the CDC report that just again, this was across multiple states, first case responders. To put it simply, out of 1,000 people, there were 161 COVID infections prior to vaccination. And after that, there was 1 out of 1,000 and they were asymptomatic. So next slide. So vaccines are incredible. I'm not really exactly sure how to overplay it. Next slide. And the CDC has given appropriate guidance at this point that vaccinated and vaccinated people can be together without masking or distancing, and vaccinated around unvaccinated who are not susceptible to severe disease like children also can be around each other without masking and distancing. Next slide. And I think we have to just really celebrate the optimism of these vaccines. We're not where we need to be in this country with rollout. We're going to get there, and we are getting there. Thank you.
Thank you so much, Dr. Gandhi, for that wonderfully informative talk. There's some really excellent questions in the chat.
Okay.
One is, Oakland Unified School District certificated staff are going to be returning mid-April. And at that point, many staff will have just had 1 shot so far. And so there's a lot of questions around, when do these shots really become efficacious? How long after the first, how long after the second until people can feel protected?
Yes. There was a model with Pfizer that after the first dose, you're 92% protected. And then the CDC data showed yesterday that after 1 dose, your rate of protection is 80%. And then a study from Israel showed 85% protection after 1 dose. So anywhere, I would say between 80 and 92 protection after 1 dose, which is reassuring, especially if you're waiting for your second dose. And then you're right, I see a question, but it is true that when I would have loved to answer the question about surface transmission, if we end up wanting to do that, maybe you already did. That it is true that we will have good effectiveness after 1 dose. And it takes about 2 weeks to develop that protection. And 2 weeks after the second dose to be maximally protected.
Thank you. And then next question, you touched on this, but it's such an important point. I want to make sure we're able to offer it again, which is when are we going to need to repeat the vaccine? Is this like the flu where we're going to need to get it annually and get our boosters?
No, I think, again, we're in a very transition period with understanding of the virus. And there's understandably a lot of people who've just kind of jumped into the mix and made a lot of commentary about that. The influenza virus has what's called a very leaky polymerase, meaning it mutates at a very rapid rate. The SARS-CoV-2 coronaviruses have something called a very strict proofreading mechanism. And they actually don't mutate quickly. I do realize that the news has been only about variants, but they don't mutate quickly. And we don't believe that once we've stopped giving the virus a chance to transmit, which is tamping down transmission, which certainly didn't happen over the winter surge, that the virus will be mutating that quickly. In addition, you actually have to compare this virus to its friends, and its friends are not influenza, and its friends are not cold coronaviruses. The most closely related viruses that cause severe disease, coronaviruses, are called SARS-CoV and MERS. And importantly, SARS-CoV, which was the first SARS pandemic in 2003, people still have immunity after getting infected, and they've looked at their blood 17 years later. So I don't actually think we're going to need booster shots for this, but I do understand that that's the next thing the news is talking about. But I don't think, not by the biology.
Thank you. Sort of related to some of what you're speaking about in relation to variation and variants, are we in for a fourth wave? And how might this impact schools?
I don't think we're in for a fourth wave in California, and it's not for great reasons. It's actually because we had a really severe third wave. So there are three reasons that I don't think cases are, we're in a very low period of community transmission across most areas in California. And the three reasons I think we're not going to see rise in cases is, one, because the restrictions that we're maintaining are prudent. We're not wide open. To be fair, by the way, there are places that are wide open and they're not seeing those increases in cases. So I do think it's also the second reason, which is, unfortunately, we got a lot of natural immunity in California. There was a California DPH study that was, the Chronicle covered it, but it hasn't been published yet, that 30% of Californians after the third wave were exposed to COVID-19. And 29% in San Francisco were the lowest, but up to 45% in LA. And then depending on the county, different rates. You can just look up Catherine Ho, San Francisco Chronicle, and there's a whole map on it. That natural immunity that we developed from our very severe surge, plus rapid application of vaccines, which we are doing. 42% of San Franciscans have received one dose of vaccine. That is so much higher than the national, which is 29.8%. Those three things put together mean I do not think we'll have a fourth surge in California, no.
Thank you. I recognize we're asking you to tell us the future.
Tell the future. Yeah, I'm pretty sure.
And then one final question, which is less directly related to what you said, but was the very first question asked to us today and comes up frequently, which is related to transmission from flushing toilet seats.
Yeah, I had wanted to answer that. Thank you. So, the reason that this even came up at the beginning of this pandemic is no one knew what was going on. I mean, and I'm so sorry about all the misinformation at the beginning, because it was sort of, everyone was writing up everything and it was all in the news and it was panic time. And so it can be spread by surfaces and fomites and toilet plumes, and none of that is true actually, but it took careful research to show that it wasn't. Again, just because you can culture it from a surface, and this speaks to the disinfection question that someone asked, to put it very cleanly, you would have to have 100 people sneeze on a surface and then lick that surface to get SARS-CoV-2 transmission from a surface. So this excess disinfection that's occurring in multiple settings, I'm actually very personally concerned about it as an infectious disease doctor, that it's going to lead to antimicrobial resistance. And I would definitely not make that a very big part of school protocols. And no, you cannot get it from flushing toilets or shared bathrooms.
Thank you.
These are questions that were asked at the beginning of the HIV pandemic. So I do understand these types of questions, but it's not true of COVID either.
Thank you so much, Dr. Gandhi. And that's actually a beautiful segue into the final part of this presentation, where we'll talk a little bit about how do we actually make this happen at school. So my name is Dr. Emily Frank. I am a pediatrician who works in the emergency room, and I also teach at Life Academy. And so ever since March 2020, I have been thinking not only what does this mean in terms of illness in this country, but what does this mean in terms of my classroom and how I work with staff at my school and how I teach kids. And so COVID transmission, next slide, please. I want to ground us in this important idea, because my goal for this 10 minutes is to help you think about when you are at school live with kids, how can we make those split-second decisions that we make every single day as educators with foundational knowledge about COVID? And how can we make those decisions in a way that keeps everyone safe and that's also sustainable for your day-to-day? And so I want to ground us, and this goes back to what Dr. Gandhi was saying, is the vast majority of COVID is spread through droplets. So droplets are these little water particles that fall to the ground, usually within about 15 minutes. That is the primary way that COVID is transmitted. Less common is aerosolized particles. So those are teeny tiny particles that are able to remain suspended in the air, but these tend to spread out as opposed to concentrate. Least common, as Dr. Gandhi brought up, is surface transmission, meaning someone's droplets get onto a surface, those droplets remain infectious, they get on somebody else's hands, and they make it into a person's eyes, nose, or mouth. Next slide, please. And so that's important, all right? You cannot get COVID infection simply from touching something, all right? The particles, the viral particles, have to get into your eyes, nose, or mouth. Next slide, please. So another really important concept I want you to take with you is what a high-risk exposure is. So a high-risk exposure is close person-to-person contact. That means within 6 feet for more than 15 minutes of someone who is infectious. So if you walk past someone who has COVID, or if you are in their 6-foot bubble even for 1 minute, that is not considered a high-risk exposure, particularly not if you're vaccinated. Next slide, please. As I talk about risk mitigation, I want to remind us of these 3 steps. So in order to get infected, the particles of the virus need to leave the body of someone who's infected, survive, and then come in contact with the eyes, nose, or mouth of a healthy person. Next slide. Let's skip this one. All right, so on the left is how the rest of the world think things work in my classroom. I can only wish. On the right is what my classroom actually feels like. And so how teaching is so hard as it is, like how on earth do we layer public health on top of that? Next slide. So we need to think about layers. And this is called the Swiss cheese model. It's adopted from the world of engineering. And the idea is that, like, if we think about our cars, there's not just one thing that keeps us safe. We have airbags, we have brakes, we have speed limits, we have stop signs, we have stoplights. There's layers and layers and layers that keep us safe and reduce our risk. And the same is true with COVID. We are enacting layers and layers and layers to help keep us and when I say us, I mean like us as a community, students, families, staff, safe. Next slide. So one really important piece of that slice is preventing the virus from leaving the body. And so to do that, it's really important that people who have symptoms stay home. And by symptoms, I mean a variety of symptoms: fever, cough, headache, loss of taste or smell, new runny nose, diarrhea, not just cough or body aches. So new symptoms that are not from ongoing conditions. And if that's something you or somebody in your household has, it's important for you to stay home until you're tested. If you're not vaccinated and anybody in your household is awaiting a non-routine COVID result or has had a high-risk exposure, then that's another reason to stay home. Staying home, I know, is so hard. I would rather come to school with the flu than try to write lesson plans for someone else. But in the times of this COVID pandemic, it is extremely important that all of us stay home if we're experiencing symptoms. Even if we think, oh, it's just a migraine due to whatever, we really need to be vigilant. Next slide. Symptom screening is out, I think, on Parent Square. I did a Google survey today, so I'm not going to dwell on this. Next slide. Physically distancing, 6 feet, 6 feet, 6 feet. No, wait, 3 feet. Wait, what? So where did 6 feet come from? The vast majority of droplets fall within 3 feet. So what we did was we said, let's be conservative. We're going to double that, 6 feet. We should all stay 6 feet apart. Next slide. And 6 feet apart is good. However, recently, some data showed us that 3 feet can be okay in certain situations. That is, in elementary schools where there is universal mask use, students can be 3 feet apart. The teacher, however, still needs to be 6 feet away, or the adult educator. Also, in a middle and high school area, if there's universal masking and low community transmission, students can be 3 feet apart. Or if there's universal mask use and cohorting, students can safely be 3 feet apart. Next slide. Who should be 6 feet apart? Adults, always, and students from adults, people who are unmasked, and middle and high school students who are either not cohorted or are in areas of high community spread. Next slide. Our school looks like this. I hope yours does too, with markers and reminders. And this I found actually educationally is the toughest thing to remind folks is remember we need to space each other. Remember we need to try to maintain our distance between each other. Next slide, please. Masking. I am short on time. You already know a lot about masks. There's 3 points I want to leave you with. 1, using 2 layers. A surgical mask covered by a cloth mask is nearly as effective as an N95. An N95 is a specialized mask that is most appropriate for those who are going to have prolonged close exposure, meaning within 6 feet for more than 15 minutes. Some of you have seen these valved masks. Those are really great for fire season and really terrible for COVID protection because they let out concentrated, it lets out your bodily breathing in a concentrated manner. So avoid valved masks. Next slide, please. What if a student takes off their mask? Well, this is why we have so many different layers of the Swiss cheese. If possible, it's great to have the student step out if they are taking off their mask. If that is not feasible, have the student step at least 6 feet away. When you lose one layer of Swiss cheese, do your best to implement the others. For students who cannot tolerate masks, I want to remind us that many students who won't tolerate can learn with time and focused goals and incremental steps. If a student absolutely cannot tolerate a mask, that is where we really need to maximize our distancing, our ventilation, our symptom screening, and all the other slices of cheese. Next slide, please. This was sort of touched on by Dr. Gandhi. So the most important thing is that that we don't have infectious droplets on our hands when we touch our eyes, nose, and mouth. And so hand washing is going to be really key. This can be with hand sanitizer as long as hands aren't visibly dirty. And this is going to be more high yield for us than these frequent deep cleanings. Now, there are cases where regular hand washing may be challenging for a variety of reasons. And in these cases, there might be more of a role for cleaning. But, well, I won't go into antimicrobial resistance, but the key tenet here is really around hand washing, and that can be with hand sanitizer or with soap and water. Next slide, please. A face shield, I just want to remind you, it's not the same as a mask. It is helpful in reminding us not to touch our face. Next slide. Cohorting. So the idea behind cohorting is that it allows for fewer exposures and easier contact tracing. Somebody asked in the chat, like, what should be the size of a cohort? How many cohorts should a child be in? So the size of a cohort really depends on students' ability to physically distance from each other. And then the question for how many cohorts should students be in? I mean, I would say ideally one cohort, but what it comes down to is how many people are you comfortable with that child being exposed to, and what is going to be the ripple effect if someone's infected on quarantining, and your ability to contact trace that and implement that. Next slide, please. I'm going to skip testing because Dr. Bartok spoke about it. Next slide. Ventilation is helpful. It is not the be all end all, but it is really helpful. Opening windows can create ventilation. Using air cleaners, air filters can help ventilation. HEPA filters can increase ventilation. Maximizing the amount of air coming from outside versus inside when it's circulating can be helpful. And so all of these are yet another slice of cheese that can help mitigate our risk of infection. Next slide. All right. We have, I think, a few unanswered questions in the chat. A lot of them are district type questions. And so if the folks from Central can help answer some of those district specific questions, that would be great. If we have a student who's constantly struggling to wear a mask, should we ask them to stay home? That's a great question and a really tough one in many ways. And so I think, first step is to try to come up with a behavior plan the way you would with any other behavior you want a child to practice, with incremental steps and incentives and positive reinforcement along the way. I would say the second step from that is to try to find a way that they can be as safe as possible within the classroom, because we know that distance learning doesn't work for many of our students. And so I think my thought would be, as a next step, is there a place in the classroom that I can put my that student that is well away from other students, that's close to a window or close to an open door or close to an air filter, to minimize what's otherwise happening. And a face shield is not a replacement for a mask. It is something, it can at least maybe prevent them from touching their face. And then especially in those cases, it's extra important that there is vigilance around any sort of new symptom.
I add just for a moment that earlier today we sent out the PowerPoint from the safety leads presentation, as well as the video from the presentation itself. And this question, both like medical exemptions and also when the circumstances under which a student might be excluded from in-person learning are detailed a little bit in there, but just to know that there's procedures being the procedures developed and being communicated through principals and otherwise to both kind of hold the value of trying to include and hold kids, but also making sure that people are protected and feel safe within the school environment.
Thank you. Do you want to close us out? I want to make sure to be respectful of folks' time.
Yes. So I'll close this out. I just want to say, first of all, just thank you to everyone who's here, across our whole community. Everyone's just incredibly busy, and I appreciate the people in the audience, joining us. I appreciate all the presenters for all their expertise and the time they put in their presentation. So I really appreciate that. Our commitment to you is that we will take this recording, we'll share it out here shortly. We'll try to package share it along with things like the safety lead volunteers. I know there's a lot of information here, and I would encourage folks who came here and found it valuable to in turn share it with other folks, because I think that this really is the people who presented here, they're on top of their job is staying on top of all this information, and I really appreciate it. And so I wanted to share that. And with that, we're going to go ahead and close the broadcast. And thanks everybody for coming. Thank you.